Welcome to the Advancing Surgical Care podcast, brought to you by ASCA, the Ambulatory Surgery Center Association. ASCA represents the interests of outpatient surgery centers of every specialty and provides advocacy and resources to assist them in providing safe, high-quality, cost-effective patient care. As with all of ASCA's communications, please check to make sure you are listening to or viewing our most up-to-date podcasts and announcements.
Hi, I'm Bill Prentice, and I'm ASCA's CEO and the host of this episode. On this ASC podcast, I'm pleased to welcome back Kara Newbury, ASCA's Chief Advocacy Officer. Hi, Kara.
Hey, Bill. Thanks for having me.
Well, I've invited you on the podcast today to discuss the final 2025 Medicare Payment and Quality Reporting Rule that was released by the Centers for Medicare and Medicaid Services, or CMS, on November 1st. CMS is required by law to issue a rule each year to authorize the procedures that can be reimbursed by Medicare for ASCs, establish our reimbursement amounts, add or subtract any quality reporting requirements, and more for the coming year. ASCA and other interested parties make proposals to CMS throughout the calendar year, and we also submit detailed comments and recommendations when the proposed rule is published in the summer. This process is one that we take very seriously, and our submissions to CMS are lengthy, detailed, substantive, and supported by clinical data when available that all demonstrate that ASCs are now the low-cost, high-quality set of service relative to hospitals and hospital outpatient departments, or HOPDs. Yet, despite our proven ability to save Medicare billions of dollars, a bias in favor of hospitals and against surgery centers seems to have prevailed at CMS under both Republican and Democratic administrations, and that's what we fight with every year. And this bias manifests itself in our constant struggle to win equitable reimbursements for the same procedures performed in HOPDs, and our yearly fight to add procedures to the ASC Covered Procedures List. Procedures, I might add, that are performed safely every day in surgery centers on patients with commercial insurance. And regrettably, the 2025 rule shows little sign that CMS is moving toward a more fair or fiscally responsible posture as it relates to surgery centers. And we'll talk more about the particulars in a moment. But before I do, I also want to ensure that our ASCA members and the entire ASC community that we are more committed than ever to redouble our advocacy efforts, both with Congress and these agencies, to change this mindset at CMS and bring about more equitable treatment of ASCs. Now, before we actually get to talking about the rule, though, I also want to acknowledge the fact that we just had an election on Tuesday, and we now know we're going to have a new administration. And that's going to obviously also involve wholesale changes in terms of the leadership of all the federal agencies, including the Department of Health and Human Services and CMS. And obviously, we won't know for some time who's going to lead those agencies, but we know that it's going to make for substantial changes in terms of how we're treated in all likelihood. And I'm going to ask Kara, when she's answering my questions about this year's rule, to maybe offer up some thoughts about what she thinks might prevail next year, particularly since we obviously have 4 years of experience with a Trump administration from 4 years ago. So with all that, Kara, let's start with a summary of the inflationary update for ASCs. Could you first explain the effect of the hospital market basket on reimbursement rates for ASCs and why it's essential that that continues? And then, of course, could you tell us a little bit about the actual update and when the 2025 rate calculator might be available?
Sure, Bill. So ASCs historically were updated based on the Consumer Price Index for all urban consumers. And as you mentioned, our update is based on the hospital market basket, which aligns with the hospital outpatient department's update. And we've long advocated for that alignment. And actually, under the Trump administration, we were able to get a 5-year trial starting in 2019 that it was extended for 2 years. And besides the fact that just philosophically, we think it's important to have alignment since our payment system is based off of the hospital outpatient department's payment system, it has historically been the case that the hospital market basket has been a larger update than the CPIU. And so that holds true for this year. We received a 2.9% effective update based on the hospital market basket. That's a 3.4% minus a 0.5% subtraction that is mandated by the Affordable Care Act. And that 2.9% is higher than the 2.6% that was in the proposed rule. This was something that we expected because other payment systems like the inpatient prospective payment system that come out earlier in the cycle than ours do showed that this trend that it was increasing. And the CPIU right now, the consumer price index for all urban consumers, is about 2.4%. So it is critically important that we stay on the hospital market basket to ensure that we are getting that higher update and that it is aligned, like I said, to what the hospitals are receiving. I've already done a quick analysis of the top codes by volume bill, and we're seeing that for the top 100 codes, it's approximately a 2.93% update, which is just slightly better, obviously, than the 2.9%. And then for the top 10 codes by volume, it's not quite as good. So it's only about a 2.5% update for those codes. So that's also just a reminder that the update will vary by code. And so make sure that you check out the rate calculator once it becomes available. It will be available the week of November 11th. So we will have that available next week based on the recording of this podcast. And that is an ASCA member resource.
Great. Well, thank you for that. We need to take a pause for a quick message from our podcast sponsor. Stand by and we'll be right back talking with Kara.
This episode of the Advancing Surgical Care podcast is brought to you by AmSurg, a national leader in the strategic and operational management of ambulatory surgery centers. AmSurg partners with more than 2,000 physicians and health systems and more than 250 ASCs operating in 34 states. Learn more by visiting amsurg.com.
Kara, as I mentioned just a moment ago, we find ourselves in a constant struggle each year with CMS trying to win approval for additional procedures, codes that we know are proven safe in ASCs and can save the Medicare program and Medicare beneficiaries substantial amounts of money. As you've reported previously on a podcast, this year was supposed to be different, at least in terms of the expectations that we would be given a more transparent process for submitting our requests to add codes. Can you talk about what we asked for and what we got or didn't get and how CMS has responded in this rule?
Absolutely, Bill. So this year, as you mentioned, there was a new portal through it, a CMS site through which you could submit codes for consideration. The codes were due by March 1st of this year. And ASCA submitted some cardiovascular codes as well as a couple of spine codes. The spine codes were lumbar fusions. The cardiovascular of particular interest to us were some cardiac ablation codes. So we were very disappointed that in the proposed rule, CMS mentioned the process in general, but did not even list the procedures that had been put forth through that nomination process by interested parties. And so we raised concerns and disappointment with that lack of transparency in our comment letter this year.
Yeah, and if I could just interrupt you right there, because again, I just want to just highlight the hypocrisy of that. Is that to create what they claim to be a more transparent process, but then not in the proposal to even acknowledge the codes that had come in through that process and give a stated position on whether or not they believe those were appropriate for our setting, thereby not giving us or any other stakeholder the opportunity through the comment process this summer to rebut or to provide new information really is unfair and something that I think we need to take the agency to task for.
Well, and thank you, Bill. You kind of teed me up. I share your outrage. And interestingly, there was some mention in the final rule, but it was lumping procedures they grouped them together. So for instance, CMS did not add the requested codes, but in reference to the cardiovascular codes, CMS said, quote, many of these codes have associated inpatient admissions where the beneficiary would require active medical care and monitoring at midnight following the procedure. Well, it would be nice to know which of the procedures that we requested they feel would require that, because the data that we shared with them, we feel does not indicate that. And then they also talked about cardioversion and echocardiography codes being non-surgical and as such not qualifying for addition. So at least I guess we got some feedback knowing why they were keeping those codes off the list. And we, along with the specialty organizations that we're working with to promote these codes, have a little bit of feedback there that we can refute. But it would have been nice, to your point, to have this in the proposed rule so that we could have included some of the data or our rebuttals in our comment letter.
I'm sorry, I was just going to say, now we have to wait a whole other year in order to kind of restate this case and rebut.
Yeah, and I think that we will obviously be submitting codes again through the portal, but as we've discussed previously, Bill, we're really going to get on the ball very early in the year in 2025, and we're going to schedule meetings with the appropriate folks at CMS and HHS, as you mentioned. With a change of an administration, it becomes a little more difficult because you don't know the timing that somebody is going to be appointed and taking over some of these roles. But we do want to get in as early as possible to make sure that we can impact the 2026 rulemaking. And I just wanted to mention with regard to the lumbar fusion, the spine codes that we have had requested, it was interesting because CMS showed that the claims data that they had in the outpatient setting showed multiple post-op inpatient days, which of course we have data and outcome that refute that. And they also indicated that they didn't feel that our studies were significant. They included, quote, selection bias and an absence of age groups representative of the Medicare population, which I found interesting considering one of our studies that we provided was an ASC who operated as a hospital without walls during the COVID pandemic. So it was specifically Medicare data. So I think a lot of work to be done there. At least they provided some responses, even if I don't agree with their response.
Right. And again, thinking about next year, we do have some experience with the prior Trump administration, where in the last year of that administration, they greatly expanded the procedure list for both us and hospital outpatient departments. In fact, I think there was an effort to do away with the inpatient only list. And of course, we don't know who will lead the agencies this time and whether they'll have the same similar mindset or not. But at least there is some hope that maybe next year we will have a more welcoming ear to our interest in moving procedures.
And obviously, with the election just taking place 2 days ago, the dust still hasn't even settled, but we do anticipate that there could be some significant movement under a Trump administration. And we do think that we have a lot of opportunity to get these codes hopefully added and bring back some of those codes, as you referenced, that were added in 2021 rulemaking and then stripped off our ASC Covered Procedure List in 2022. So more to come for sure.
Yeah, we have obviously many months to try and get this all sorted. And of course, nothing is we can take for a given, and we're not promising anything. Just looking at what we know from the prior administration and what we think could happen going forward. So, Kara, we also need to talk about the ASC Quality Reporting Program, a place where I think you and I both share a tremendous amount of angst. In fact, I just got off the stage a couple hours ago speaking at a state meeting where we had a discussion about the quality reporting program and the direction it's heading right now. I think a lot of shared amusement at best and really outrage at worst about what's happening with that program. And as I trust all our members know, 2025 will usher in a requirement to begin collecting and reporting OSCAPS data. We also have the COVID-19 measure still on the books, despite our opposition. And for many ACs, the onboarding of doing like the OSCAPS survey is proving to be a very time-consuming and costly process. We know there's a lot of frustration with the COVID measure. Despite those challenges, CMS has now added 3 new quality reporting measures related to health equity commitments and measuring social drivers of patient health. And one of these measures will be voluntary in 2025 and 2 will be voluntary in 2026. But ultimately, right now, all 3 will impact payment determinations at future dates, not altered or repealed. And Kara, I'd like you to very briefly describe each of these new reporting measures. And we clearly don't have time to fully unpack each of them today. We'll do that at a later date on probably a podcast devoted just to them. But I will say this, even though we strongly support the concept of health equity and access to care for all patients, we have really strong reservations about the approach of these measures and their effectiveness. So Kara, with that, the floor is yours.
Oh, thanks, Bill. Yeah. So the first measure is the facility commitment to health equity measure. And that will begin with calendar year 2025, which is, of course, next year. reporting for 2027 payment determinations. And it's not similar at all to the safe surgery checklist, but I've been using that as an example because it's similar in the fact that it's like an attestation. And so facilities will be attest to the fact that they are doing certain things within the various domains regarding commitment to health equity. Unfortunately, too, if you can't check all the boxes within a domain, you can't say that you are meeting the commitment in that area. And so you would lose the quote unquote credit. Obviously, we're still a pay for participation, not a pay for performance quality reporting program, but you don't have negative information out there about your facility, especially when you can't help it. So for instance, one of the domains includes a requirement that you use an electronic health record technology. So any facility that's could not check that box and they would miss that domain. I think we've mentioned in frustration in the payment rule, CMS basically just said ASCs should implement EHR technology. Well, that's nice, with the rising costs and the meager increase to our rates. Where is this money coming from? That's one thing we'd like to ask CMS. And so we are talking about, should we pursue funding for that? Nobody get excited on this podcast. We don't think there's an appetite to give us money for it. But as we all know, hospitals did get funding for EHR. So that's the first measure, starting right away, collecting data next year. The other two measures are regarding social drivers of health. So a screening and then screen positive. So facilities would have to screen patients for different social drivers of health. So are you food insecure? Do you have issues retaining housing, transportation? I heard you talk, Bill, on a presentation, I think last week. You said this could lead to some awkward conversations. Now, of course, in the rule, CMS said, well, you can do it in a portal preoperatively or all sorts of things that may or may not have and have access to. But our ultimate question and concern is the ASC the appropriate setting for this? And truly, we don't believe it is. But CMS doesn't even know because none of these measures have been tested in the ASC setting. So they don't know how facilities would truly operationalize any of this. And to make it mandatory, starting with data collection next year, that first measure is just, we think, overly burdensome for our facilities. So we're very disappointed in that. And of course, we were also disappointed that ASC 20 remained. Since we were talking about a new administration, I will note that I do think that removing the COVID vaccination measure would be something of interest potentially to a Trump administration. So that's something that we will strongly advocate for, as we have been advocating for the last few years. And then, of course, OSCAPs. I feel like I need to mention that OSCAPs does go into effect January 1. So I hope that facilities are really selecting vendors and getting ready for that, because there was no change in the rulemaking and it will go live on January 1 for ASCs.
Well, Kara, a lot to unpack there, and we're going to continue to work on these things. With a change in administration, I think I will obviously be redoubling our efforts to try and kind of right the ship in terms of, the ASC payments and quality reporting with CMS. But I want to thank you and your entire ASCA Government Affairs team that work with you for the work that you've done all this time on the CMS rulemaking process. I know how frustrating it is. And suffice it to say, the final rule belies the enormous amount of work and advocacy that we perform on behalf of ASCs and the ASC community every year. So thank you and good luck with our work as we try and kind of figure out what's going to happen next year.
Thanks, Bill.
And finally, if anyone listening has additional questions, please don't hesitate to contact us or visit the ASCA website where more details about the 2025 final payment rule can be found.